Assalamu alaikum. I'm DrNAS. We are again here with the new topic and very important topic in the cardiology, that is the stable ischemic heart disease. So what we're gonna discuss here, we will discuss the difference between the unstable and the stable plaque, and what is the stable angina. Actually, what is angina and the different types of angina. Then we will just go through the risk factors of the stable ischemic heart disease, and then the history and the symptoms, which type of chest pain should be there, its characteristics, and their non-invasive investigations, which we actually do in stable ischemic heart disease. And then we will move towards the therapy, and we will discuss that each drug in which we use in stable ischemic heart disease. Then after that, in the last, we will discuss the the management, the invasive and the non-invasive both, and the trials which actually support to the invasive therapy, and which invasive therapy should be done in which sort of patients in the stable ischemic heart disease, and we will enlighten it with the trials and data. So let's start with the stable ischemic heart disease. Stable ischemic heart disease. So the word stable actually shows that there's something is going stable. Stable means peacefully in your body, and it won't harm you until and unless it would be affected by any other factors. Same is here. You will take a cross section or sagittal section. So what actually happens, this is a sort of unstable or ACS plaque, and this is a stable ischemic heart disease. Same is here, this is unstable or ACS, and this is stable ischemic heart disease plaque. What happens actually in the stable ischemic heart disease, the plaque might be the bigger one. In ischemic heart disease, the plaque might be bigger one, and in unstable angina or sort of ACS, the plaque might be smaller one. But the actually what happens here, that the foamy cells are in less number here, but the lipids are more here in stable ischemic heart disease. But the capsule, the fibrous capsule, is actually thick, very thick, and it won't rupture actually in stable ischemic heart disease. But in the unstable plaque, the fibrous capsule is actually thin, which can easily be ruptured and get the aggregation of platelet and thrombus, and causes the complete or incomplete occlusion according to the symptom of the unstable angina, which is not our topic. So we discuss here that the capsule is actually thick here. Same is that plaque might be smaller, but the capsule is thinner, which is prone to rupture, and it gets ruptured easily. It can be ruptured easily. And here the actually plaque is bigger one, but capsule is also thick, which won't get ruptured easily. So that is the crux, that is the important thing in the stable ischemia, that the plaque is very much stable here. That's why it won't get ruptured. But the anything which increases the demand or decreases the supply causes what? Pain, angina. That's why stable angina always occurs on exertion most of the time, until it would be on the advanced stage, which we will discuss later on, that what sort of classification we have. So first of all, we need to understand about the pathophysiology and the background of the stable ischemic heart disease, why it is stable, and what is the difference between the stable and unstable angina. So it is very we don't have like a bigger margin to differentiate. It is very important to differentiate this unstable and the stable, because there is a very little margin very it is actually very difficult to differentiate these two modalities, because anytime this stable plaque would be unstable, and anytime unstable plaque would behave like a stable one. So actually, to differentiate the stable plaque and the unstable plaque on history and the symptoms is the major task for the cardiologist. To looking the patients with the history which seems like stable angina, but that patient has unstable plaque, is actually a dangerous thing which we face in our clinics. Okay, so we will discuss here all these things. I hope that you would get my point, that what is the difference between a stable and the unstable plaque. Now the important thing is clinical presentation, how these stable ischemic heart disease patients present in our clinics. So the important one is the risk factors. Start with the risk factors of your patients, that do they have diabetes, hypertension, family history, and hyperlipidemia, and what is the age. So actually these things tell you that is your patient susceptible to the coronary artery disease or not. Is your patient is going towards the coronary artery disease or not. So if these factors are present and patient is a middle-aged male, so obviously you need to evaluate your patient for the stable ischemic heart disease. But if your patient is younger one and doesn't have this risk factors, obviously then your threshold would be lower one. But if your patient is elderly, and few of these things he or she has, then obviously again you will rule it out if he or she has atypical symptoms. So actually risk factors give us a direction that where we have to go, and how aggressive we should be with our patient with the non-invasive investigations. So risk factors guide us that how you will evaluate your patient on non-invasive investigations. So risk factor is the important thing. What is the important aftermath is symptoms, and obviously as we know that the angina word came from anchon, okay, and anchon is a Greek word which means strangling or discomfortness, but here angina means chest pain. Okay, angina pectoris. Angina means pain and chest means pectoris means chest. So angina means chest pain. So we need to dig out that which sort of chest pain should be there in your patient to diagnose him or her as a stable ischemic heart disease patient or a patient of stable angina. So as we discussed earlier that first of all, location of the pain. Location of the pain should be above the umbilical, below the chin, at the lateral border of the arm, most of the time here. And which type of feeling he or she has, that they will tell you that Dr. Saab, I am feeling strangling like situation, chest heaviness, and I don't know what is happening with me, but there is something I am feeling not well. Any sort of discomfortness above the umbilicus, below the chin, here, substernal or the lateral part of the arm or lower part of the jaw can be cardiac pain. Okay, so how we would differentiate it further? The trigger, which sort of trigger they have. Obviously most of the time, as I told you, that unstable angina, pain of the stable angina would be triggered by exertion. So it would triggered by exertion. Why? Because in exertion you are actually increasing the demand. If in any situation in which you increase the demand or decrease the supply, the pain of the stable angina occurs. Okay, so here you are increasing the demand by triggering or by giving a trigger of like exertion. So actually patient would feel the pain with exertion. But there are few phenomena with these triggering factors, like walk-through phenomena. Second is walk-through, and the warm-up phenomena. In walk-through phenomena, patient will tell you that, Doctor Saab, whenever I start walking, initially I feel pain, but aftermath that pain would get relieved. So, and in warm-up, they will tell you that at the initial episode when I do the exertion, I feel pain, but when on the next time when I perform that the same sort of exertion, that then I won't get pain or I won't have pain. So actually these things are because of the collaterals, because when patient starts doing exertion, their collaterals would open, and their collaterals actually supply the additional blood to the heart, and patient would get relieved of the angina. So don't take it light, don't take it like a non-cardiac or atypical symptoms, but these are actually typical symptoms if they are patient are coming to you with the walk-through and the warm-up phenomena. Special triggers like winter, any other associated things can also cause what? Angina, like hyperthyroidism. If patient has a because of hyperthyroidism, patient has a tachycardia, so obviously the demand would increase and patient may have angina. So these conditions may cause, and these things may be the trigger for the angina in your patient of the stable ischemic heart disease. Now we come to the point that what is the decubitus? Decubitus angina. Decubitus is actually the angina which gets relieved by changing the position. It is just because of the flow in the certain positions, flow increase towards the heart, which actually give some relief to the patient with angina. So decubitus is relieving of the pain of the angina by changing the position. So please don't take it as well as a non-cardiac or the atypical symptom, but it might be the typical symptom in your stable ischemic heart disease. And sometimes patient complain about chest pain or angina while sleeping, which we call nocturnal angina. So this nocturnal angina is because of the nightmares, and most of the time when you will take the history from your patient, they will tell you that the Doctor, I was with the nightmares in my deep sleep, then when I woke up, then I started feeling some chest discomfort is with me, and I was tachycardic at that time. So in nightmares might the patient face the tachyarrhythmias or tachycardia, which actually increases the demand and causes the nocturnal angina to our patient. So these are the few triggers with the unstable with the stable angina in the stable ischemic heart disease which your patient actually faces. Now the important thing is character. As we discussed that the character could be anyone, but the heaviness and strangling, these are the most common symptoms with your patient. But your patient may complain like the hot and cold sensation and choking like symptoms. Sometimes they complain about the short of breath, sometimes they complain syncope or pre-syncope, sometimes they complain about impending to doom, sometimes they complain about your fatigue, profound fatigue. Doctor, I can't do work while doing minimal exertion or extraordinary exertion. And sometimes they complain about the weakness, light headachehness. These all might be the symptom of stable ischemic heart disease. So don't take light. If your patient tells you that Dr. Saab, I have a hot and the cold sort of sensation here while I am doing the exertion or these things, so you need to take these things especially very serious in your patient with the risk factors which we have discussed earlier. Okay, so these are also and these things which are actually do not come into the domain of the chest pain or the characteristic of the chest pain, so we call them as an angina equivalent. So these things might be the angina equivalent, or you can like call them as a equivalent to the angina or equivalent to the chest pain in the patient with the, especially with the risk factors. Now the important thing is duration. What duration should be there in your patient, as we discussed in the ischemia, in the acute coronary syndrome, that any pain more than 20 minutes, most of the time 20 to 30 minutes would be what? Acute coronary syndrome or MI, because less than it won't be MI. At least 20 to 30 minutes are required to develop an infarction with the ischemia. So any pain which would be 3 to 5 minutes at least, but it may be your patient may feels the pain up to 15 minutes, but any pain which is beyond 15 or 20 minutes would not be the stable ischemia but an ACS or unstable angina. So look, that it is actually very important to differentiate between the stable plaque and the unstable plaque, because the pathophysiology and the actually the physiology of the pathophysiology and the molecular level and the molecular like all these things of the plaque in the stable and the unstable are very distinguished, and their treatment are also different. So you need to actually evaluate them, that if that is your patient is with the stable plaque or unstable plaque. Because if your patient has an unstable plaque, so he might have developed anytime he might develop what anytime any cardiac emergency. But if your patient has a stable plaque, then you do not worry about them, because might your patient is with the like a stable course of disease or is with the like a stable course of cardiac disease. So now here that the pain and the duration of the pain is actually important. Any pain less than 1 minute is not non-cardiac, because cardiac pain can't be like less than 1 minute. It should be more than 1 minute. It should be it should have a duration of more than 1 minute. Any pain which has a duration of less than 1 minute won't be cardiac pain. So these are the actually important things which I needed to discuss with you guys. Now the classification, which is actually very much important, that how would you differentiate your patient on the history, that in which class they lie and how would you treat them. The most important one is CCS, Canadian Chest Pain Score System, which is important and very easy to understand it. Don't worry and don't be afraid of these scoring system. Always apply these scoring system with your in your clinic practice, in your clinical practice, because when you will apply these scores, then you will learn by heart these score systems. So what is the class 1? Any activity beyond ordinary work is class 1. Suppose if your patient is hawker or a fruit hawker, or your patient is like living at the on in apartment which is on 3rd floor. So if he is giving you the history that Dr. Saab, I always climb 3 floors, but yesterday I went to my neighbor on the 4th floor, and then when I went on the 4th floor, at that time I felt pain or strangling situation, then you should rule out about the stable ischemic heart disease, because might your patient has a CCS class 1 of angina. Got it? So any pain which is beyond the ordinary activity, that if your patient does walk of 3 miles, 2 miles, but any day if he or she walks more than 3 miles or 4 miles, then they develop what symptoms of chest pain or any symptom which is angina equivalent, then you should rule out your patient for stable ischemic heart disease, that because your might your patient would have this stable heart disease of CCS class 1. So now what is the class 2? That chest pain on ordinary activity, that initially he was climbing up to the 3rd floor, but now when he goes to home or his apartment after his office time or in evening or for any reason, so he or she has to he or she has to stop because of the chest pain, or he or she feels chest pain while going to the home by climbing 3 floors, wherever he or she they were climbing their climbing 3 floors few days back, and or few days or few months back, and they won't get symptoms at that time, but now they are complaining of chest pain while climbing 3 floors. Okay, or if your patient walks 3 to 4 miles, like 3 miles or 4 miles, but now if he or she walks 3 or 4 miles, then now he or she develops the symptoms or the chest pain, then it means your patient has a CCS angina too, because now he has a chest pain on or the same ordinary work which he or she used to do in his or her past. Okay, now what is the 3? That chest pain on minimal activity. Minimal activities like usual activities, usual chores like bathing, okay, changing the clothes, like going to washroom. So these things, when these things actually cause chest pain, so we called it as this, your patient has class 3 angina, and chest pain on rest is class 4. Simple as that. So it is very actually very it is very easy. Any chest pain on beyond ordinary activity is class 1, and on ordinary activities is class 2, and the minimal exertion is class 3, and chest pain on the rest is class 4. Now we discuss here the Braunwalds classification of this stable ischemic heart disease, which is actually very important. Most of the time our seniors ask about the Braunwalds classification, so don't fret of this as well. It is very easy classification. So it has actually 3 things. Braunwalds classification has actually 3 things. One thing is the severity, actually severity, okay, and second is the clinical presentation or cause, okay, and third one is response to treatment. So what is the one in severity? That any chest pain which is exertional or accelerated, or it means it is getting worse within a short time, and this pain would be like sudden onset sort of chest pain, so you would classify it as a class 1, okay, class 1, Roman 1. And the class 2 is what? Class 2 is your chest pain which is subacute in nature. This chest pain would be subacute in nature, and this chest pain would be not less than 48 hours. it should not be less than 48 hours. Like this pain, this your patient would be complaining of the chest pain, which he or she has been feeling for like more than 48 hours. So that pain would be would have a history of like what, more than 48 hours, not less than 48 hours. Or we can write here that this chest pain would be for more than 48 hours. Okay, or any chest pain which is in less than 48 hours, okay, like sort of acute chest pain, it would be the class 3. So simple on the severity basis, if any chest pain which is rapid onset, accelerated, exertional, it is class 1. In the Braunwald classification, any chest pain which has the duration of more than 48 hours or up to the weeks or months, that would be the subacute in nature and class 2. And any acute chest pain which occurred in less than 48 hours, and like its initial episode starts in less than 48 hours, you would say that this is the acute chest pain, and according to the Braunwald classification, it is class 3 chest pain. So now we will discuss the these are the according to the Braunwald classification, this is the severity score. And the next thing, we have the clinical circumstances. So what is the A? This actually clinical presentation tells us the cause of the chest pain in Braunwald classification. A means secondary. Secondary means that your patient won't have a atherosclerotic sort of disease, but for any reason he or she has increased the demand or decreased the supply. For suppose if your patient has hyperthyroidism, and because of the hyperthyroidism your patient has tachycardia, so that would be the secondary cause. If your patient has anemia, and because of anemia your patient has developed the symptom of the stable ischemia, then your patient has what? Your patient has secondary angina. Okay, it's not primary. If your patient has the accelerated or exertional angina because of anemia, so your patient has actually 1A angina according to the Braunwald classification. Okay, now B. What is B here? B is like primary. Primary means that because of atherosclerotic disease, if your patient has the risk factors and he or she has a history of stable ischemic heart disease initially, or he or she has presented in your he or she is presented in your clinic with the symptom of like atherosclerotic disease, then you would say and that angina is exertional or accelerated, or if he or she has angina for more than 48 hours and subacute in nature, then you will tell that this is angina 2B according to the Braunwald classification. Got it? This is how we actually write the Braunwald classification or quote our patient with the Braunwald classification, or classify our patient according to the Braunwald classification. And what is the C is actually post infarction. And what is the period of post infarction angina is it should be less than 2 weeks. It should be equal or less than 2 weeks. Okay, if your patient has a infarction more than 2 weeks, then you won't like labeled him as a C. Okay, if your patient has an anterior wall MI like 10 days back, and now he is coming to you with the acute exertional chest pain, then you will tell that this is a 1C. Got it? So this is how we classify our patient with the Braunwald classification, and it is very easy. 1, 2 and 3. 1 on no therapy, you haven't given any therapy. If your patient is coming with the primary cause, secondary cause with exertional accelerated therapy, and you haven't given any medication to him, then you will label him or her as a 1A1. This is how you use your this is how you classify your patient according to the Braunwald classification. Second is like if your patient has a atherosclerotic disease, or he has a sort of exertional accelerated pain, and your patient is on like anginal therapy but not maximal anginal therapy, so you would tell, or you would classify him as a 1B2. Got it? This is how you classify your patient according to the Braunwalds classification. And 3 is on maximal therapy. So this is the exertional, subacute and more than 48 hours, acute less than 48 hours, A secondary because of any secondary cause, B because of the primary cause, C is post-infarction angina. Here is on medical therapy, without medical therapy, on medical therapy, and on maximal medical therapy. This is how you differentiate, classify your patient of stable ischemia according to the Braunwalds classification. So we have discussed the CCS classification and the Braunwalds classification, and now we move towards that what else you can do with your patient. Obviously you need to do the ECG in your patient after all this clinical examination and all these things. Obviously in stable ischemic heart disease you won't get any remarkable clinical examination with your patient. So you would get done the ECG ECG, and you may appreciate the Q waves and anything like most of the time our patients of the stable ischemic heart disease have a normal ECGs, normal sort of ECGs, but excuse me, if he or she has a history of like old MIs, so they may have Qs and or any insignificant things. Or if your patient is coming from this stable sort of chest pain, but he or she has a depressions or anything